This is Dr. Edney. I'm going to teach you how to read an MRCP, or how I read an MRCP. So essentially, my search pattern for MRCPs is about the same as an abdominal CT. The first sequence I start with is our coronal T2, and this is nice just to get an overview of the patient that you're looking at. This is our largest field of view, so this is going to be one of our only chances to look at the thorax, the breasts, especially on a female, and some of the lower abdominal and pelvic bowel loops. So important to keep those things in mind. And then I just look and try to get a general sense of all the solid abdominal organs. So I'll scroll through the liver, the spleen, both kidneys, the adrenal glands, maybe sometimes hard to see on the coronal, the pancreas, and the gallbladder here, which we can see is abnormal. Then our next sequence is the axial T2 single shot. And I do the same thing on this, going through the liver, spleen, kidneys, adrenal glands, pancreas, gallbladder, stomach, duodenum, and upper abdominal bowel loops. And for all of those, I'm looking for their morphology, their attenuation, any specific lesions that I might see. So in the spleen, here's a T2 hyperintense lesion. Most commonly, this will be a cyst or hemangioma. So we'll keep an eye on that on our post-contrast. And like I alluded to on the coronal T2, we saw that the gallbladder was abnormal. We see these punctate foci of low signal laying dependently in the gallbladder, which are stones. The gallbladder has a lot of irregular high T2 signal around it, which is pericholecystic fluid and inflammatory change. One of the main things that we're going to pay special attention to on the MRCP are the intrahepatic and extrahepatic bile ducts. So we really don't see much in the way of intrahepatic ducts on this patient because they are normal, they're not dilated. But we can see the common hepatic duct here leading to the common bile duct as this tubular high T2 signal, and inserting at the ampulla into the duodenum. And we're going to look for any filling defects, dilation, or obstructing lesions around the common bile duct. We can also often see the pancreatic duct. Here we just see a little slip of the pancreatic duct within the pancreatic head, and that looks normal. We want to keep an eye on pancreatic ductal anatomy, any dilation or irregularity or lesions connected to the pancreatic duct as well. Next, we can move on to our diffusion weighted imaging. So on this side I have the B750, and on this side the ADC, which I usually have to window down. And we'll scroll through. I focus on the diffusion and look for anything that's bright on the image. So a lot of times this is useful for finding subtle hepatic metastatic lesions as bright foci that you wouldn't notice on other sequences. Lymph nodes also look really bright on this series. So just a quick pass through that. Then we can look at our MRCP specific sequences. These are just different projections that are heavily T2 weighted and give us a nice layout of the biliary system. So even though it was tough to see the intrahepatic ducts on the axial T2, you can see them out to a pretty far distance on this MRCP sequence, and they look normal again, leading to the common hepatic duct, common bile duct, and you can see the pancreatic duct in its entirety there. The cystic duct is also often seen, but in this case is surrounded by a lot of inflammatory change, so it's difficult to see discretely. We have MRCP sequence specifically made to look at the pancreatic duct, this axial pancreas. On this case, it was easier to see the pancreatic duct on our general radial MRCP. Next, we look at our bolus sequence quickly, just as the contrast bolus is injected to make sure that the lungs enhance symmetrically and completely to exclude any large incidental PE. After that, we have our axial T2 fat sat. And this is nice just because I think it gives more tissue contrast with T2 bright areas. You can see here, if you didn't notice that the gallbladder was abnormal on the regular T2, it really stands out. Here, the same is often the case in pancreatitis. subtle or mild pancreatitis is most obvious on the T2 fat set. And my favorite is using this for lymph nodes. You can see the lymph nodes are the brightest thing on this image. All these bright clusters around the periportal region. They tend to look not as bright on the regular T2. You can compare here. So here's on the T2 fat set, and here's on the regular T2. They're just kind of that intermediate gray signal. Very easy to miss here, very hard to miss here. Next we do our in and out T1 weighted imaging. So we'll scroll through here to the in phase, and on this side to the out of phase. And mainly we're seeing the liver and spleen. Do they lose any signal on the out of phase, suggesting that they contain microscopic fat? And here the liver does lose signal, so I would say this liver has mild steatosis. We can look at other lesions more specifically as well to see if they contain microscopic fat, or the India ink artifact to suggest macroscopic fat. This patient doesn't have any lesions that we're going to look for this case. And lastly, we're going to finish up with our post-contrast imaging. So I like to scroll through the T1 pre-contrast first, which I have here in the upper left-hand corner. Look for any T1 bright lesions. Normal pancreas should be the brightest thing on this image, and in this case it is, because the pancreas is normal. And then we're going to look through all of our other organs for any lesions that might be enhancing on the arterial phase here, the venous phase here, or the delayed venous phase here. We can see that the liver is really diffusely, heterogeneously enhancing on the arterial phase. I don't see a discrete lesion in this, but it looks abnormal. But it normalizes by the time we get to the venous and the delayed venous phases. So this is really typical of diffuse hepatic inflammatory change, probably because there's something going on with the gallbladder, and that inflammation and engorgement is spreading into the liver parenchyma. Another search pattern checklist item for the post-contrast is to look at our vessels. So the abdominal aorta, its branches, the celiac, superior mesenteric, bilateral renal arteries, and inferior mesenteric arteries. Make sure all those are patent. We try to look specifically at hepatic arterial anatomy a lot of times to see if there are any variant anatomy that we should bring to the clinician's attention. And then in a similar vein, we can look at the venous structures. So there should be 3 hepatic veins leading into the IVC. We should see the left, both branches of the right, and the main portal veins leading to the portal venous confluence, the SMV extending inferiorly, the splenic vein contributing to that portal venous confluence, and then the IVC and renal veins as well. The last thing on my checklist is to look at the mesentery and the retroperitoneum. Again, just like an abdominal CT, see if there's any ascites, inflammatory change, retroperitoneal or mesenteric adenopathy. And then finally, we have our coronal post-contrast. This is our furthest delayed post-contrast sequence. So sometimes it's useful when you're looking at a liver lesion, for example in HCC, to see if there's a pseudocapsule or to see if there's washout. They can be more conspicuous on this coronal post-contrast just because it's our furthest delayed. And again, this gives us a bigger field of view than most of the rest of the exam, so we really benefit from having contrast. In the mediastinum, you can see lymphadenopathy there, or masses. In the breasts, this is a male, but you can see a little bit of gynecomastia there. And then in the lower bowel loops, you can sometimes catch a colon cancer or a small bowel mass on this sequence. And finally, this gives us a nice overview of the osseous structures with contrast. So important to look for any enhancing bone metastases. So just to wrap this up, we saw the gallbladder contained stones, had pericholecystic fluid and inflammatory change. We can see on the contrast that it shows progressive delayed enhancement of the gallbladder wall, and this was a surgically proven case of chronic cholecystitis. I think it's difficult to tell without clinical information in this case if it was acute or chronic, but on surgery this was chronic. I have one more case here just to show an abnormality in the bile ducts. So on our coronal T2 where we started, here we can see the common bile duct extending down near the duodenum, and in this case it's dilated, measures up to 10 millimeters, and kind of gradually tapers as it gets close to the pancreatic head. And here with the arrow we can see a tiny filling defect. This is a really dark T2 signal, suspicious for cholecystectomy. This patient has had a cholecystectomy, so we want to cross-reference that suspected abnormality on the axial sequence. And if we try to match the same level as the coronal, we can see again there's a low signal filling defect in the common bile duct laying dependently. So this is an example of cholecystectomy. We know that this is not artifact because it's in the dependent part of the duct, so pneumobilia a lot of times will be non-dependent, and other things that can cause this look are crossing vessel, which you would not expect in this location this far down along the common bile duct. And this patient, just for sake of full disclosure, has acute necrotizing pancreatitis, cholecystectomy, a drain in the right upper quadrant, pleural effusions, ascites, very complicated.